I'm actually not an MD. I am a PhD trained genetic epidemiologist and bioethicist and data scientist. Just some disclosures, I'm currently leading the largest public release of American Indian Alaska Native genomic data through the All of Us research program. I also co-founded the Native Biodata Consortium, which I'll talk about very briefly. I also recently served as a guest speaker for AbbVie, and I'm on the clinical advisory board for Cache DNA. So I first want to talk about this focus about rare variant research and its potential impacts for Indigenous peoples. But I first want to start off with a story that is rooted in my own culture. I am Navajo, as I mentioned, and introduced myself in Denep-Bazad. But one of our central tales is that we were told to choose between two yellow powders. One was tratadine, which is what we use, corn pollen, for many of our blessings and ceremonies. And then the Dian, the holy people, told us, great job, but leave the other yellow powder where it is. And the other yellow powder is hlitzo, which is uranium, which also means a form of monster. And we were told to keep it in the ground, and if we were to remove it, it would bring evil. So in the rise of like the machinery of World War II, specifically at the end, there was this heightened interest in utilizing uranium for what ended up becoming the bombs that were deployed over Japan. But there was also another story that was happening in northern Arizona particularly, which was that of uranium mining. In particular, miners were given no ventilation, no masks. The fans that are actually turned off until OSHA workers came and then for the inspection, and only then they would turn it on. Even though the Surgeon General warning had not happened yet, there was still some percolating preliminary data to show the link between lung cancer and smoking. So the supervisors of the miners are actually encouraged them to smoke cigarettes, so that later when a lawsuit occurred about the increased rates of lung cancer, they could blame it on the cigarette smoking as opposed to the uranium mining. Even worse, it wasn't just something that impacted the workers themselves, but also their families and their children. Oftentimes, the workers would come home with their uniforms caked in dust, and then, of course, their family would be around that dust. But then even when the mines closed, especially these open pit mines were left open, and they would fill up with water, and oftentimes it would irradiate the ground system because it's a sedimentary rock, it's very porous, and also it would just irradiate the water, the very water that was used to mix formula in many cases for children. So the toxicity or the amount of uranium that was imbibed by a pregnant woman was something of order of 3 liters of water a day, and she was exposed at uranium levels at over 100 times the federal maximum. We don't actually know what those levels are. At some point, the state public health department actually issued radiation badges to the families and then never released the actual data related to the actual exposure. So this is a quote: "We washed our faces in it, we drank in it, we ate in it, it was sweet." So it's very interesting because if you track the literature, the medical literature related to this increased childhood condition now called metachromatic leukodystrophy, it was one that was actually ascribed specifically to inbreeding. And in journals, they couldn't even call it what it was, genocidal events for the long walk history, but they basically whitewashed it and stated, oh, it was due to population bottleneck in the late 1800s, and then afterwards further inbreeding that caused a heightened predominance of this variant, contributing to Navajo neurohepatopathy, which is what they called it. So the term incest was used, despite the fact that we have our own clanship systems, our own ways of tracking our family members, and the language was just riddled with colonial language, and the language on culpability shifted away from state in the U.S. and onto the families themselves. Yet everyone tried to shy away from the very obvious link related to uranium. So a concern is that genetic predetermination is often used as the root cause and not other environmental or obvious factors. This is of concern because every time we think about shifting to green energy, which is good, but every time that conversation comes to the relative reduced cost of uranium, there's an increased interest in re-engaging uranium mines in northern Arizona. So we have to think about here the environmental justice or injustice, and then also the racism systemically imposed upon our peoples. So in terms of clinical trial representation and also cancer prognoses, we have a high rate of malignant neoplasm, which is highly prevalent in our communities with poor 5-year survivability rates, and disproportionate disease burden of renal carcinoma, especially in this geographic part of Arizona. Yet representation of Native Americans in clinical trials is incredibly low, 0.3%. And it's not a matter of, and this is a point I'll iterate a couple times, it's not a point of just getting more Native Americans into clinical trials. It's really understanding the history, which is one that we still live in, thinking about historical trauma, trying to make inroads towards trust, and really thinking about perceived benefit, ensuring that we're not just making promises about their participation in research and then turning around, extracting data and genomic data, but really ensuring that communities benefit sooner rather than decades plus later. This is incredibly important because when we started the Native Biodata Consortium, which is an indigenous-led biological data repository on the lands of the Cheyenne River Sioux tribe, we had a soft launch at the American Society of Human Genetics, and afterwards we had several pharmaceutical companies ask us how many people are enrolled or represented in your databases and across what phenotypes. And we came prepared with a list of conditions that were prevalent for us, but less prevalent in the dominant population. Things including metabolic conditions and other childhood conditions. And we asked a simple question: why don't you study or allow us to study these conditions that primarily impact us and allow us to use our DNA for those types of research? And the pharmaceutical companies said, you constitute less than 3% of the US population. It is not profit generative for us to explore those types of research studies, which tells you everything you need to know about the term democratization, which is not a synonym for equity, but it's really more a majority rules sort of situation. And that kind of scenario will always disenfranchise disempowered individuals. And it's not going to be solved by recruiting more indigenous peoples into studies, nor is it going to be solved by just dropping supposedly free clinical tests in our communities. It has everything to do with a disproportionate amount of funding to preventative care and also access, which has become more disproportionate post-pandemic. I recently led a meeting at Cold Spring Harbor where we discussed the implications of indigenous reference genome, and I invited Adina, one of our first women Surgeon Generals for the Navajo Nation, and she stated that genomics medicine will never be a benefit to our peoples amid all of these other structural concerns related to inadequate funding, poor infrastructure. If you want to look and think about health disparities, I love the Phoenix Indian Medical Center. It services 177,000 indigenous peoples in the Southwest. It's the largest ISH facility, but if you drive by it, you'll understand that we need more funding to preventative health and less towards genomic medicine, especially when you consider that at the start of the pandemic, we actually lost our maternity ward. But when we think about the lack of access to clean water and what that does, and especially in terms of public health measures for like washing your hands to curb viral transmission at the start of the pandemic, and just simple fact that there are other colonial factors like the removal of our ability to practice our traditional ways of living and also our ways of diet and agriculture. When we think about how an IHS patient is referred, oftentimes IHS clinics are usually in rural areas, and if a patient wants to seek clinical testing, genetic testing, they have to be referred out by their PCP to an urban-based clinic, sometimes 3+ hours away, over 100 miles one way, one direction. So that's time off of work, that is finding someone to take care of your kid, that's a working car, that's gas, and at least one hotel night stay. There is something to the fact that even with the recently expanded ACMG panel, that only a handful of these 74 medically actionable gene variants actually have information specific to Indigenous peoples, which should ask the question, how useful are tests for people who are Indigenous if they're not well reflected on the tests anyway? And do clinical providers or genetic counselors know how disparate that lack of information is? Is there training available to deliver culturally specific care? Are patients fully informed about default data sharing? What are the risks for Indigenous patients who seek care through federally sponsored programs like IHS and VA, who are not protected by the Genetic Information Non-Discrimination Act? This is a scenario that I call the catch-22, that when presented a question about whether or not to contribute DNA for genetic testing, some Indigenous peoples might say no because they can't afford or access the test. But those that agree may not also know that they agree to implicitly broadly share and have their secondary data used and owned by testing companies. And given the background, the lack of relative clinical utility, we have to ask whether or not this is of adequate benefit to Indigenous peoples. Now, I understand that the cycle of commercial co-optation and ownership is usually outside of the context and realm of providers who are just concerned about delivering the best care possible to each patient. But these are questions that are of concern to tribal nations and some Indigenous peoples, that just by simply prescribing a clinical genetic test, you're also facilitating the ownership and co-optation by that company to that data, which might be subverting Indigenous data sovereignties. There's also a requirement to deposit novel gene variants into public databases. But there's also a concern here that there have been a number of well-funded NCI studies that have propped up in urban centers like Arizona, Tucson, and Albuquerque that just by nature of having an oncology specialty unit have also started recruiting cancer patients without actual express permission from neighboring tribal nations. And then also utilizing that for other research that may be against certain tribal nations' existing moratoria on genomics research. So in response to a lot of these questions related to trust, and also in terms of trying to keep data local to Indigenous peoples so that they could build better research questions that interest them, we started several years ago, as I mentioned, the Native Biodata Consortium, because we wanted to give tribal nations and their leaders an alternative to build a non-federal data repository that actually services tribal nations. It turns out that when you build a data repository on tribal lands in full view of tribal members, and they know who work in that data repository, and you operate within tribal law, that they actually feel more empowered to engage in the research process. Not only that, but we can build better research questions as Indigenous scientists, because we understand that the cultures and the ways of living, we can understand how to better gauge non-genomic and non-health factors contributing to health outcomes, and also have improved population descriptors and modeling. So when we were able to institute a next-gen sequencer at the start of the pandemic, little did we know that this would actually translate to increasing tribal sovereignty and build research capacity in other spaces. So for instance, right at the start of the pandemic in South Dakota, tribes had to export their nasal swabs usually out of state to a testing facility, and in many cases they would get results back 14 to 15 days later. So imagine what they did for initial viral transmission. Just by having a sequencer local with a CLIO-certified laboratory, we were able to pilot a surveillance program that returned those results back within 24 hours. We've also been able to expand our understanding of gene variants in the Lakota communities in which we work with for outcomes related to rheumatoid arthritis and other autoimmune conditions. When we asked elders what are factors that contribute to your decision to participate in health and genomic studies, we actually learned quite a lot of interesting facts. But one, that Tribal Nation members rated job and education opportunities created by health research higher than the benefits of the individual benefits of researching a disease or condition. So this kind of makes sense because I used to work in the Turtle Mountain Band of Chippewa Indians in North Dakota, which is not far, 6 hours driving distance. It's just not far in the rural Dakotas. But one of the Anishinaabe teachings is like related to the 7 grandfather teachings and also thinking 7 generations in the future. So there's this notion that for every decision that we make, it should be something that benefits those that can't come after us. So a huge question and a huge point of interest in participating in research is how can we ensure that the data benefits our future children, and how do we also think about reversing this export of talent. So there's a huge the so-called brain drain where indigenous peoples have to leave their communities to get higher degrees, but there's not really a space or a setting for them to utilize that advanced education. So by having a laboratory that's centrally located that does health-based research, we've been able to encourage many of those members to return. But this also speaks to this difference in terms of like Western versus non-Western dynamics, and I use that in quotations, because a lot of our informed consent forms are on an individual notion of autonomy and agency, and that's already culturally incongruent with indigenous worldviews, which leads towards group consent or communitarian ethics. So what that basically states is that the informed consent forms that we're giving to indigenous patients are already incongruent with their beliefs and their practices, which is something that we need to change. And especially related to DNA just doesn't re-identify one individual, but it can re-identify everyone that you're biologically related to, which means that it just takes one member of a small community, and especially since we have large family sizes and small generation gaps, it opens up the possibility for genomic racial profiling. And this is where simply removing personally identifiable information does not negate that risk of re-identifiability. As a bioinformatician, there are several bioinformatics papers that show with that as few as 3 parameters, you can actually re-identify somebody based off of their genomic profile. So my last point that I'd like to say is that I'm happy to return after being trained in other spaces to Arizona State University so that I could start the largest indigenous research laboratory with 12 different trainees, 9 of whom are indigenous. But one of the things that we want to do is bridge qualitative research with quantitative research, not just looking at genomic determinants of health, not just looking across the electronic health record, but also thinking about community-grounded research to think about those other things that we miss in terms of phenotyping across EHR, so that we can have a more holistic model and really understand what are the drivers related to health disparities in our communities. Yeah, thank you so much.